Thank you for taking time from your busy day to watch this special presentation from the El Paso County Medical Society. I'm Dr. Joel Hendricks, President of the El Paso County Medical Society, and it is my hope that you will find our program of great interest, educational, and informative about the medical care provided by some of our best physicians in our country, right here in the borderland. From all of us at the El Paso County Medical Society, please enjoy tonight's program.
How important is it to get regular cancer screenings? In our community, there are a significant number of cases of advanced cervical cancer. This is likely due to a lack of proper screening in the past, also limited access to healthcare services, poor follow-up, recent immigration status, specifically here in our community, and missed opportunities for vaccination and other preventative measures. And where does HPV come in? That's the human papillomavirus, and that has gained a lot of media recognition over the last several years, especially because of the vaccinations. Where does that fit into all of this? Our goal this evening is to educate the community and provide preventable measures and treatment options for women, and today specifically discussing cervical cancer. During the next hour, we have experts answering questions about all kinds of female issues, again, oncology specifically with females, and this is underwritten by Sparrow Women's Oncology Center, and a big thank you to the El Paso County Medical Society for bringing the show to you for over 26 years. I'm Catherine Berg, and this is the El Paso Physician. Thanks again for joining us. Today we're going to be talking about female oncology, specifically cervical cancer. And we have with us this evening Dr. Travis Mendel, who is a radiation oncologist. And he's been on the show several times in the past and actually brought the show to us this evening. So thank you so much for being here. And we also have Kayla Castaneda, who is a nurse practitioner who works a lot with Dr. Mendel. So Dr. Mendel, true to form, we were talking about this before we started. For a radiation oncologist, and specifically in this discipline, what is it that you do all day, and what is it that you're bringing to us this evening to discuss?
So as a radiation oncologist, I guess first of all, I work with Rio Grande Cancer Specialists, which is a subsidiary of Rio Grande Urology. But we treat solid tumors for the most part with radiation. It's typically external beam radiation. We have something called brachytherapy, which is an internal type of radiation. And then we also now have what's called theragnostics or radionuclide radiation, where we actually have injectables that target cancer cells. But specifically for cervical cancer, gynecologic malignancies, we're usually doing external beam treatments and brachytherapy for this. Okay. So I see the patients typically after Kayla does, or if the patient's also undergone surgery, we'll see them in clinic and then make recommendations on whether or not those patients need radiation as an adjuvant treatment option or even definitive with chemotherapy.
And just interviewing you over the last several years, there are so many new things when it comes to radiation oncology. I mean, every time you come here, it's like, oh, we're going to talk about this now, but guess what's coming in 6 months? And that's something I'd like to talk about too, just in general, what's always on the horizon. It's always very exciting to talk to you about that kind of stuff.
So, sorry.
Yeah, go ahead. Please go ahead. Yes.
Okay, sorry. So with cervical cancer, really the techniques haven't changed that much. We still do external beam. We follow that up with usually with brachytherapy. The technique of the brachytherapy has changed and somewhat evolved over time. We're able to introduce catheters, interstitial needles into the tumor so that we can spread the dose out more laterally in the patient, more to the sides, so that you can cover the entire tumor. And obviously do that safely while protecting the rectum and bladder, these organs that are important to the patients.
When you're talking about this too, I'd like to, what might stay in the body, what duration of time is. But anyway, that's something we're going to talk about in a little while. But I wanted to make sure that I say that out loud so you can remind me as this hour goes on.
Absolutely.
Kayla, let's talk about you. So nurse practitioner, I feel like that's a title that covers so many different things. But specifically with what we're speaking about tonight, what is your scope of duties, so to speak?
So I'm a women's health and oncology nurse practitioner. So I have two specialties. And with these specialties, I have a practice which is called gynecologic oncology, which is essentially treatment of female reproductive tract cancers. Okay.
Okay.
This includes cancers of the cervix, of the uterus, of the fallopian tubes, the ovaries, the outside of the female parts, which is called the vulva or the vagina as well. Those are all parts of the female anatomy that we treat in this specialty called gynecologic oncology.
Okay.
And so my typical day is involved with seeing patients who are either in the beginning of their treatment journey, which could include anything from surgery alone to chemotherapy to radiation. And immunotherapy is another type of treatment that is in the cervical cancer arena and in the gynecologic cancer arena. And so I'm treating those patients. I'm also seeing patients that have already completed their treatments, and they're in what's called surveillance, where we're monitoring them periodically to make sure that if their cancer does come back, we catch it at a very early time and are able to institute therapies quickly in order to help to retreat the cancer if it's needed. And unfortunately, I also do care for patients who are at the end of their life and who may not be doing so well and may need to stop therapies at that point. So from the very beginning to the very end, gynecologic oncologists, and which are the physicians I work for, and nurse practitioners like myself, we work in a multidisciplinary team with radiation oncologists like Dr. Mendel, infusion nurses, hospital staff, staff in the clinic, nurses. These are all part of our what we call a multidisciplinary or multiple people team to take care of patients throughout their journey.
Okay. What are screening guidelines now? What were they a couple of years ago? What do you perceive them being? And to your point that we talked about prior to the show, they seem to be lightening up a little bit on screenings, which I think is odd. I shouldn't say I think it's odd. Sometimes you think, okay, well, if things are okay for a while, the screenings have gotten so good that they were able to find something earlier than in times past. And is that why? And I'm just throwing that out there. I know that's kind of a loaded question, but we brought it up before the program. So in general, what are screening guidelines now for cervical cancer?
So is that for me or is that for Kayla?
That's for Dr. Mendel. Or unless you want to throw it to Kayla, we can do that too.
So kind of like I talked about before, I feel like I have to look them up every time.
Okay, because it's changing all the time.
Every single time I look at it and I'm like, okay. And then I almost always immediately forget it because I know I can look it up later.
Okay.
But also when I look it up or if I try to remember it, the next time I look at it, it's like different. It's always different.
So who's in charge of changing it? So is it the American Cancer Society guidelines or National Cancer Institute? How does that work, and who decides what the guidelines are going to be in a given year?
There's actually different sets of guidelines depending on which group, like cooperative group you're going to follow.
Okay.
I don't know all their names to be honest,
that's
but
fine.
But they have their different screening guidelines. I'm not sure which one Kayla generally follows, but.
So they, you can go anywhere between, the one that's probably the most conservative, which is the U.S. Preventative Task Force.
Okay.
And so that one, they have their screenings, they're basing it on a population, and they're looking at cost as well,
Right.
and whether it's cost effective to screen so frequently. So usually their recommendations are usually much more conservative, and that's because they're probably more fiscally conservative.
Okay.
And then the ones that we usually follow are something called the ASCCP, which is the American Society for Cervical Cytology and Pathology, and that's the one that we use for cervical cancer screenings. There's also the American Cancer Society. They have a set of guidelines too. So just like he said, there's multiple organizations that you can follow. There's other organizations like the American College of Obstetrics and Gynecologists. They have their own screening, their own type of guidelines as well. So as a provider, you really have to decide which one you want to follow.
Right.
Usually,
so it's not mandated on any specific.
No, absolutely not. It's not. And so that's what kind of makes things a little bit confusing, not just for patients, but if you can imagine, we're confused sometimes too, because they change, like Dr. Mendel says.
Yeah.
He has to look them up all the time, and so do I.
Yeah.
And then once you start getting into where you have abnormal screenings, then that's a whole nother set of ways to manage things. And so then you really are using, a lot of the stuff that we use now is we use apps where we input what the patient's pap smear was, what was their biopsy, so on and so forth, what's the next step, and that kind of helps us to follow what kind of guidelines
So
specifically.
what right now, even off the top of your head, if you don't know exactly without looking it up, what are the screening guidelines now? Like, what is the
So right now,
mandate?
I would say following the ASCCP guidelines, that the screening guidelines are starting at age 21.
Okay.
And not before. Women should start having pap smears with what we call. So when you do a pap smear, there's different things that's happening. So whenever you go in for your pap smear, you're not when you're going. Let's say this: whenever you're going in for your well woman GYN exam.
Right.
Okay.
And we want this to be once a year. And I want
Right.
to stress that. So
Yes.
no matter what the
Yes.
guidelines say, this is always good to go in
Exactly.
once a year. You talked about cytology, you talked about other
Right.
things too. So let's make those specific
Right.
to
And
the
so that's
cancer.
one thing actually that as providers, we need to do a much better job of educating our patients about the difference between a pap smear and a well woman exam. So a well woman exam is when you're going in, you're getting, you're looked at from head to toe, you're getting a breast exam, you may or may not be getting labs. They're taking a look at all of your female parts. So not just your cervix, which is inside where they have to insert a speculum, but they're also looking at the vulva, which is the outside, the vagina. Then they're going to do a bimanual exam to feel your uterus and see if sometimes they may or may not feel your ovaries. So whenever you have the actual pap test is when they're putting in a speculum, they're going in and they're using different things. They can use a spatula with a brush, or they can use something called a cervical broom. And they go in and they're taking a sample of the cells that are shed from the cervix.
Right.
Okay. In addition to that, you may also have an HPV or human papilloma virus test. Okay. And so that's the difference. There's two things that may be happening at that time. So whenever the screening guidelines say from age 21 to age 24, you should be having just the cells taken, not the HPV test, every 3 years, okay? That doesn't mean you don't see your gynecologist, but every 3
Exactly.
years. That
Nice
just
that you bring
means
that up.
that
Right.
he or she is just doing the pap test every 3 years. But every year when you go in, they are looking at the cervix and making sure they don't see anything abnormal that they may need to biopsy or do a workup on or do other things, checking for sexually transmitted infections, so on and so forth, or any
Right,
other types of
right.
infections. So then from ages 25 into age 65, then you would do either that cytology alone, again, that cells,
pap smear.
which is the pap smear alone, every 3 years, or you could have a pap smear with an HPV test, which is preferred. That is the preferred method
So I'm
together.
going to ask a quick question here. Is that something that the patient advocates for themselves? Like, does the patient then ask on their own, say, Doc, I would like to have both. I would like to have the cytology test, which is a pap smear, and I'd also like to have the HPV test. Or is that what the doctor and or screener decides on their part?
So in my opinion, the patient is in charge.
Excellent. That's why we're here. This is all about
The
advocacy.
patient is
and
in charge,
Exactly.
and
Good for
we
you.
are here to help work with the patient and to guide the patient as to what the recommendations may be. However, the patient is in charge,
Right.
but the preferred is that test, the pap smear with the HPV test together every 5 years.
Okay.
And so then, or it could be just the HPV test by itself with no sampling of cells alone every 5 years.
This does get confusing.
It's very confusing.
This is very complex.
It's very complex.
So if a patient, and I'm just trying to think of myself and my daughter, as she's growing into years and she's of childbirthing years. Sorry, Annika. She's 26. But to me, I always look at these programs like, what am I teaching my kids going forward? And to your point, every year, honey, you go in, you go get your girly checkup. That's what we talk about. So on that note, do I, as a mom, does the audience as parents and or people within the ages of 25 to 60, do they then advocate, well, every 5 years, I want this and that and the other? Do they know what they're asking for? Or do they, like most women, frankly, they'll go in every year and they just get whatever tests are given to them and then they go away and they wait till next year? They usually say, okay, what time next year would you like to come in? And you go again. So it's almost like this rote thing that women do. And Dr. Mendel, you're kind of looking at me with a bit of a nod. So I'm going to turn things over to you.
That's if they go.
That's if they go. Good
so
point.
The big problem we have in our patient population is a lot of our patients don't go to the doctor. And if
Okay.
they do, they wait forever. So I have, almost every patient I see for cervical cancer, they're usually young, like young women in their 20s and 30s.
Oh,
And I
my.
ask them, I'm like, how did this happen? Tell me, some of them have been having these symptoms for over a year, vaginal bleeding, pain, and they just didn't go, they didn't have insurance. They didn't know who they could go see. They just didn't, they didn't have access.
So
And it's a
you're opening
big
up a
problem.
beautiful can of worms. And I'm going to call it beautiful because I think this is a place where we can educate if people happen to be tuning in. If they're having symptoms, you mentioned vaginal bleeding, you mentioned pain. What other symptoms are there? And where do they go if they don't have a doctor that they see regularly?
So that is a great question.
It's a terribly loaded question. I'm sorry, but it's super
fine.
important for people to hear.
So you can think of the symptoms progressing as the tumor obviously grows and gets worse. So it starts in the cervix. That's obviously in the pelvis. It's usually starts right at the os, like it's the opening into the uterus from the cervix. That's usually where these start. And so it has direct access to the vagina. So these tumors are usually friable. The blood vessels aren't formed well, and so they bleed. So bleeding is, a very common symptom that the patients will have.
And I'm going to interrupt really quick. As a patient, how would you know if you're having your period or if you're bleeding abnormally? Is that associated with the pain? And I'm just trying to think of what my daughter would ask me.
And that is
so
a
I'm
very,
throwing that out
very
there.
common, like what the patients tell me.
Yeah.
They say, I thought I was having my period.
Right.
It didn't go away. Or I just kept getting my period every like 1 or 2 weeks and it kept getting worse. And then, sometimes they'll eventually go in to see someone, but it's been going on for a long time. And they just they didn't know where to go, what to do, or they just thought that they didn't have insurance, so they couldn't see anyone. But it's a difficult situation when you don't have insurance. UMC has all kinds of programs, discount programs for patients that are uninsured, and so even at the least you show up to the ER, right? So if you're having vaginal bleeding and it's been persistent, you're having pain, problems urinating, someone's going to do a speculum exam,
right,
and they're going to find something,
right,
and that'll at least get you plugged in to someone.
Yeah.
But
this is something too, and I do want to bring this up because I think when we talk about in general genitals, right? It's not something people want to talk about. It's embarrassing.
Yeah.
Who am I going to ask about this? What am I going to say once I get there? I'm embarrassed about it. If we could somehow, it's so easy for us to sit here and talk about, well, the stigma. Don't be embarrassed, go do it. But what is it that you relay to your patients when it comes to talking about stuff that they're not comfortable speaking about?
So I usually try to make them feel comfortable with the situation. And then I also try to help them realize that this is something we're doing all day, every day. So you're not the first person we're investigating these symptoms. So usually it's all about, communicating with the patient what you're doing, making them feel comfortable, and, helping them understand the importance of these procedures. But kind of getting back to the original conversation, a lot of these, if patients would, get screened, if they would get their vaccines, these number one diseases or at least cervical cancer itself is somewhat preventable or wholly preventable. But also you can catch it earlier.
Right.
So, there's the staging process, which we can go through, but really based off of, how advanced the tumor is, that leads down to what treatment options the patients have. If you catch them early, the treatments are not as invasive as they are once they come to me, where we're doing chemotherapy and radiation and all these much more morbid
So I love that
options.
you're saying that this is preventable. So let's now switch gears and really highlight the HPV vaccine. Again, 26-year-old, and I say this because when she was young, turning into an adolescent to a teenager, this is something that her pediatrician now, okay, well now this is not mandated, but it's the recommendation now from the pediatrician office to get the HPV vaccines. I think there were 2 at the time. So this is, when I say new, 20-ish years, which is still in my book kind of new. How important is that, and where do they get their vaccine? Is that you can only get through a pediatrician? Can you get that through clinics? Can you get that at a drugstore, et cetera? So talk about that, because that's the push, right, of trying to get people to get their vaccines.
Well, I had my vaccines done at just one of the county service vaccine buildings.
Okay.
And I remember
And tell people
I
what
was
that
in med
means.
school.
When you say that, what does that mean? County service
So they
building,
have,
where would that be?
there's, mine was on off of Donovan, I think. They
Okay.
have different immunization centers.
It's called Immunize El Paso.
Thank you.
Right. I
Yeah.
was going to say, how did you know to go there? Thank you very much.
Immunize El
and we
Paso.
may even have a website for that. I think it's called
Yes.
immunizeelpaso.com.
It's called Immunize El Paso.
Perfect.
Yeah,
Okay.
and honestly, I don't even think, because I was within, I didn't pay anything. I just showed up and got it. And I think it was a series of 3 injections. But I remember I was in med school when I got it. And I remember learning about this and being like, I need to get this.
Right. And so on that note too, we talked a little bit about this when we were, before we went on air. You're a boy, you're a guy, you're a man, you're a male. I say all the wrong words. But in general, again, years ago, it's like, well, that's something that the girls have to get. And it's like, wait a minute, the boys have to get this too. And you talked about too, mouth and throat cancers. You talked about all kinds of things. So when was it that this wasn't just a vaccine that the females had to get? This is also something the males had to get.
So I don't know when, but the reason why is because the males are the ones spreading it. Right? So we're the ones spreading it to the females. So you need to, help stop the source, and that'll help prevent the spread of this virus. And there's different types of the virus, different like serotypes or whatever they call it. But there's hundreds of them, and there's high risk versions, and that's what the vaccines protect against. HPV 16 and 18, those are the big ones for cervical cancer. And there's a couple other high risk types, and that's why there's different vaccines now. They had the bivalent, now they had the quadrivalent. I don't know if they have
Nonavalent. It's 9.
9 now.
Then they have 9.
So,
And it includes high risk and low risk types. So high risk types are generally the types that cause cancer. Low risk types cause genital warts.
Okay.
So that's a part of it too. And so the nonavalent, or what it's called Gardasil 9, is a vaccine that protects against both genital warts and against the low risk types, and then from cancer from the high risk types.
I forgot about the warts.
Yeah.
Totally forgot about them.
Oh, well, trust me, I can't forget about warts.
No, in the world of oncology,
They see
we
it
just
all the
think
time.
about it preventing a cancer, but there's a lot of, not everything, but there's a lot of other things that it can prevent as well.
Correct.
On the guidelines of that, what age, if you have that off the top of your head, what age do you start receiving the vaccine? So you're looking at 3 different jabs at this point. I'm assuming that's still the case, right?
Well, for children, it's actually only 2.
Oh, for the children.
Children
in my
only
head,
get
I have
2.
from earlier.
So children get
Okay.
2. I believe, I can't remember the exact cutoff age, but I want to say 15. Age 15 is the number that sticks in my head. At that point, it turns into 3. So at one
Okay.
point, it does turn into 3.
And the hope here is the desire is before sexual activity.
Correct.
Is that correct?
That
That's
is
like the main thing.
and that's the
Okay.
reason why they're starting vaccination so young.
Okay.
So anywhere between ages 9 and 11 is when that series is starting. And it just really depends. So if you look at a vaccine schedule for the children, they'll probably give it whenever they're going to need their next, booster or
The
something
well
like
baby,
that.
the well child.
Yeah. So whenever the next
vaccination sheet.
booster is, then they'll probably give it with that.
Okay.
Yeah. And so it's usually 2.
I think another thing just to point out, just for parents, that it's so I can see a scenario where a parent walks in, their kid's 8 years old, the pediatrician is saying we need to give them their HPV vaccines. My daughter or son is not sexually active. Right. So but they need to understand that it's going to protect them for the rest of their lives. Right.
Exactly.
Or provide protection for them. Not immediately, but it will. So. And I think that leads kind of back to the stigmas, right? The parents are like, no, I don't want. There's a big vaccine, hunt nowadays,
pushback, yeah.
but I think that the parents just need to realize that this is not, not the pediatrician isn't thinking that their 8-year-olds, participating in these activities. They're just trying to protect them for the rest of their life.
Right.
This horrible disease.
And Kayla, on that note, since I feel like sometimes you're the line that people see, when there are parents who are, gun shy, so to speak, of certain vaccines, what's the narrative that you and your team usually provide in that case? Like you said, saving lives, but when you're really trying to convince, for the lack of a better word, to really educate a parent as to why this is important, what is that narrative that you all use?
So one thing is to just, assure them. I mean, because also in my, in my field, I do birth control as well, right? And so, a lot of times patients, parents think, well, if I put my kid on birth control, it's going to make them more sexually active, right?
Yeah.
And so sometimes you'll get that with the HPV vaccine. If I give my child the HPV vaccine, that's just giving them an invitation to be sexually active. And so, first of all, just kind of squashing that stigma. And having that conversation. And then telling them that, cervical cancer is a horrible disease and it's preventable. And why would we not want to prevent a horrible disease that can possibly take their life or severely affect their abilities to live a normal life, have children? Some of these women that we see are haven't even had children yet, and they already have cervical cancer. And so these are important things that I like to have, I like to point out to them that this is what we're trying to prevent here. And thankfully, since I work in an oncology office, I'm able to tell sometimes I tell my patients who have had cervical cancer, and they may have younger children, please make sure that you get your HPV vaccine, because you don't want your daughter going through what you're going through. We want to prevent this from happening.
Right. So there's also that thought process too. When you have a vaccine, it's against a virus. And so this is a virus that can cause cancer. So I think some people have a hard time wrapping their head around that. How is it that a virus is causing cancer? Is breast cancer caused by a virus? Is lung cancer caused by a virus? You see where I'm kind of going with that, right?
It's actually fascinating.
Yeah, and so that's what I'd love to just bring up a little bit, because I think that's the hurdle that people are, or at least in my experience, people are not understanding that. How can a virus cause a cancer? And again, maybe the narrative that you talk about when you said that's fascinating, that it is a virus. It causes a bunch of things. It's not just cancer. A bunch of, we're talking about warts, we're talking about all kinds of things. How do you wrap someone's head around that?
So actually, I was thinking about this earlier. They have I put a diagram on that PowerPoint. I don't know if you all flip it up, but basically the virus, when it affects the cell, its whole sole purpose is to hijack the cellular machinery to make more virus, right? And you have to do a couple of things. You have to stop the cell from dying. You have to take over the machinery for DNA and construction of the actual viral proteins. And HPV itself manipulates two tumor suppressors. One's called P53, which is actually called the guardian of the genome, and it is the mecca of cancer genes. And it's when I was taking courses in college on cancer, it's like the first protein you study, because it's supposed to be the guardian of the genome, and it has its hands in all kinds of different cellular processes that protect the cell from becoming cancerous. So that's number one.
And the virus attacks that.
Yeah, the virus manipulates it. It basically inactivates it, so that the cell doesn't know something's wrong, essentially.
I see.
And then the other one is the retinoblastoma tumor suppressor as well. So those are the two main proteins that it interacts with. But the virus isn't trying to cause cancer. It's just trying to make more virus, right?
Gotcha. Which is why it's trying to live. That's
exactly.
Gotcha.
And but once it does manipulate these two tumor suppressors, it makes the cell more predisposed to develop into a cancerous cell. And so that's why it's so important to stop the virus and prevent the infections.
So I may be going down the rabbit hole a little bit on this, but again, virus, right? And this is, let's say somebody gets the virus at the age of 17. Can it stay dormant? And is that even the right word to use for years and years on end? When does it become active? And again, I don't know if those are answers that you can answer, or has that been studied quite yet? So you have the virus, you're sitting on it, and all of a sudden at the age of 50, now we've got cervical cancer. Is it something that could have been activated in your body at the age of 17, 18, 19, in their 20s, et cetera? How does that work, or do we know? We may not know.
I think Kayla probably knows more about this, but there are different flavors of dysplasia, and I know that when you, of course, I've never had a pelvic exam. I've done many pelvic exams.
Oh, they're fun. You should have one just for fun. No, just kidding. Not that you can do that.
Yeah, you never know.
I know.
You never
Went down
know.
somewhere else. But Kayla, let's attack that question.
Yeah.
So what happens is that once you get contact with the virus, and so it's usually through sexual contact that you get the virus. The virus may or may not be active. So just because you have the virus doesn't mean that it's active. And so that's what makes it really tricky because you can have the virus in your body, but the tests that we use is looking for active virus and it can be dormant. Okay. So you can have a normal pap smear your whole life and never test positive for the virus. But then it can be reactivated. And the way that it's activated is by your immune system. So if your immune system is lowered for whatever reason, and one of the big things that likes to activate HPV is smoking. So that is a huge risk factor for cervical cancer is smoking. And so that's one of the first things that we tell our patients that may be smokers that have cervical cancer, stop smoking.
Interesting.
And so it can turn on and turn off. I have patients that 1 year they're HPV positive, next year they're negative. Then they're HPV positive, next year they're negative. Really? Off and on, off and on, off and on. When it's inactive and it's dormant, it's not doing anything. It's not causing any problems. But when it becomes active, that's when it starts having problems. So there are mechanisms in our body that can turn that HPV off. But when those mechanisms fail for whatever reason, and usually because of a lowered immune system, then that's when it becomes active, and then that's when it starts to attack. However, HPV is a slow-growing virus, so it has to be active for a prolonged period of time in order to actually start making changes and turn into cancer.
So when you say a prolonged period of
years.
time, years.
I'm not talking
your face
months.
When you said that, years.
Years, not months. So when patients tell me that when I see a patient with cervical cancer, they have had active virus for years.
Goodness.
So and that's the reason why they have the extended intervals in the screening.
Gotcha.
So remember your question about that. And that the reason why is because it's a very slow growing cancer.
So here's a question. When you said a moment ago that 1 year you will test positive, next year you'll test negative, then positive, then negative. When someone tests positive for the HPV virus, what are the actions to be taken next?
So usually the next thing that will happen is an exam called a colposcopy, okay? And what that is that we're using a microscope essentially to look at the cervix to see if we can visualize any lesions that the HPV is causing. So any changes, we're looking for any changes that the HPV virus causes. And the way that actually happened, that we can see it, is we actually use vinegar.
You use vinegar.
We use vinegar.
Used for so many great things.
So we actually use, it's acetic acid, and we use vinegar. And what we do is we put vinegar on the cervix, and areas that are infected with the virus and that are starting to make changes, they turn white. And then we're able to visualize those abnormal cells. Now, these are before they ever even turn into cancer, because the cancer usually doesn't turn white. By that point, if there's a cancer, it's different. It looks yellowish in appearance. It's easily bleeds if you touch it. But those, what we call dysplasia, which is just a fancy word for abnormal cells. That's all that means. So that dysplasia, we're able to detect that before it ever turns into cancer and do things to get rid of it before it ever turns into cancer.
So I just had my colonoscopy yesterday. A lot of this sounds similar to me in what is happening during a colonoscopy. You go in, you see a polyp, you remove it before it turns into a cancer. So when you're talking about now, you're going into the cervix, you see lesions, for the lack of a better word, you see something that's suspicious, that doesn't look good. What do you do then? Do you physically remove them? So you go in and actually scrape them out?
First thing you're going to do is you're going to do a biopsy. And then you'll send that off to the lab, and you want to see what's the grade, or how aggressive is this quote unquote dysplasia? How likely is it going to turn into cancer? So dysplasia is graded as mild, moderate, or severe, or grade 1, 2, or 3. Okay, so mild dysplasia, normally your body, so women's bodies get rid of those abnormal cells on their own. They shed those cells. So that discharge that you have every month, that normal, or every day, that normal discharge, those are your cells coming off, okay? Your body can get rid of those mild changes on its own.
Does your body know to do that?
Yes,
if it has?
yes, it's very smart.
I mean,
And also,
aside from like on an everyday thing, but if your body knows that there's something abnormal happening, is that something that's, in other words, does your body know you have HPV?
yes,
Does it know that you're positive, and does it start shedding on its own?
it sheds those cells. Those cells are going to come off on their own. Okay. However, if your body is not able to take care of it, and that HPV infection, so that's where that continued HPV infection, if it's still present, your body hasn't been able to turn that off, and it's persistent and it keeps going, then those cells are going to keep changing and changing and changing until they finally turn into cancer. But not all dysplasia turns into cancer because we have those mechanisms in our body that help to protect us. And so once they get to what we call intraepithelial neoplasia or dysplasia 2 or 3, at that point, it's very unlikely that your body's going to be able to get rid of it on its own. And so that's when we come in and we have interventions that we can do to help with that.
So describe an intervention. Describe what you are doing physiologically to the body to help get rid of these.
So we can do anything from what's called cryoablation, which is a freezing procedure where we actually freeze the cells and then they melt off. We can use a laser where we go in and burn the cells and then their body sheds them off. Or we can do an excisional procedure, which is where we actually go in and physically remove tissue with either a knife in the operating room, where we just kind of cut out in a little cone and remove the part of the cervix. Or we can use something called a leap, which is a hot loop that we use that we can kind of shave off that part, the abnormal cells, to get rid of them so that you're left kind of with a clean slate. But then the body has to do its job and it has to fight the virus so that you don't continue to have the same process over and over again. And that's where it's really important for us to be doing the vaccinations, because that does help us as well. And it also, so the vaccinations, just to clarify, is to prevent that neoplasia or abnormal cells 2 and 3, not 1. It's not going to prevent 1, okay? It may or may not, because 1 doesn't always turn into 2.
Say I forgot what 1 is already.
So 1 is mild.
Okay.
1 is mild.
1 is mild. Okay.
So mild,
Okay.
moderate, or severe,
Gotcha.
right?
Okay.
So the vaccine,
you still have mild hanging out.
you can still have
Okay.
mild hanging out.
Okay.
Because mild, usually your body takes care of it, so it's not a big deal. We're not worried about it. It usually goes away. Rarely does it turn into the other part, only when our body's not able to do what it needs to do. So the vaccine is preventing against moderate, severe, and cancer.
Okay.
That is the purpose of the vaccine. So what ends up happening many times is I have patients coming in and saying, but I got the vaccine.
Right.
So why am I here? Why do I have these abnormal cells? And I have to remind them, the purpose of your vaccine was to prevent you from having moderate, severe, and cancer. That's what the purpose was, not to prevent the mild. Because mild, we can deal with mild. No big deal. Our body can usually take care of it.
So I'm going to go backwards here a little bit. So when we're looking at, again, because I want to go back to treatment. So we're looking about all the physiological things that you can do to the cervix itself, to the lesions themselves, to remove them. I'm going to switch over to Dr. Mendel for a moment and talk about radiation. So when and where, I guess when in this process, would radiation be now a resort to go to when it comes to cervical cancer? So we talked about in the opening that there are more cases of advanced cervical cancer, and you're talking about 1, 2, and 3.
And that's not cancer yet. It's just
and that's not cancer yet. So we're looking at, this is still in the preventative stages.
Correct.
And now we're migrating over to Dr. Mendel. And now we're looking at some advanced stages. And then I want to, if you don't, and don't let me forget, because you also said that follow-up after cervical cancers, I do definitely want to talk about that too, the surveillance afterwards. But where does radiation come in with advanced cervical cancer? And tell me what options there are and how that's performed.
So you can start, I mean, if you are able to throw up the slide that has all the stages and then treatment options for that,
and that's something
that would be a great thing to show.
Okay.
But basically you start, from early stage cervical cancer, it's usually a surgical disease. Once it becomes invasive to the point where we're worried that the cancer is going to come back, that's when radiation comes in.
Okay.
And so it's usually, there's different criteria. One's called Sedlis criteria. This is after the patient's had a hysterectomy.
Okay.
And the cervix removed. Right. So if the tumor is large, greater than 4 centimeters, if it's invasive, usually more than a third, or if they have lymphovascular invasion, like it's starting to go into the lymph channels, those are all risk factors for the tumor coming back. And so we usually use those risk factors to guide us whether or not the patients need radiation. Also, patients can potentially need chemoradiation after they have a hysterectomy, and that's called the Peters criteria. And
oh, yes, I remember that. Okay.
And it's funny because it's everyone in residency, we have to remember these little acronyms, and so it's Peters, but it's positive margins, parametrial invasion. So that's for positive margins, they obviously remove the tumor. There's still some tumor left behind. That's a positive margin. If it's parametrial invasion, that's the tissue that's next to the cervix. If the tumor is invading into there, that usually requires chemoradiation adjuvantly. And then positive lymph nodes is another. If they'll usually do the hysterectomy, they'll remove the ovaries and they'll also sample the lymph nodes. If the lymph nodes come back positive, that's an indication for adjuvant chemoradiation.
Okay.
And usually if the patient has a positive margin, they'll get brachytherapy with an applicator called a cylinder.
Now I'm going to stop for a moment too, for those people who don't know what chemoradiation is. Describe that phenomenon, because usually you have chemo or radiation. And so right now you're combining these two words. So describe what that means.
So what we're doing is we're using the chemotherapy to enhance the effects of the radiation. So patients will usually get radiation treatments daily with these type of cancers, and it's usually for 5 to 6 weeks.
Okay.
They'll receive external beam radiation to the pelvis and then the draining lymphatics as well. Once a week, they'll get chemotherapy.
Okay.
And that basically sensitizes the tumor to the radiation and improves the patient's survival. That's why we give the chemotherapy
So they're doing chemo
along
and
with it.
radiation at the same time.
Yes.
Okay.
Yeah, and so of course it's more toxic, right? You have, radiation's pretty, it's toxic, it's not terrible. The chemotherapy on top of it can make it a little bit more, the effect's more substantial. But you want that because you have more cancer and you want to kill the cancer. So, but the patients, they do well. And of course, there's a lot of coordination that goes on with these, and that's what makes these cancers so difficult. Because Kayla and I are always calling each other, trying to figure out where we're at with the patients and things like that. Because we work in different clinics, and the patients can be difficult sometimes because they have their own lives and things going on, and it's this massive effort to coordinate and get everyone, like the whole team, together to try to treat these patients. And I think we do a pretty good job. Yeah.
Seems like you guys got it together.
Yeah.
So here's a question too, because we were talking about cervical cancer usually spreads the ovaries, then we look at lymph cells. So certain cancers spread to certain organs quicker than others. And this one is natural, goes to the ovaries. From there, metastasis is always the word I'm thinking about. With cervical cancer, advanced cervical cancer, where does it like to go once it spreads from the cervix?
So usually before I do my treatments, we almost always order a PET scan.
Okay.
We talked about this in the last program.
Right, yes.
But there's a type of PET called FDG PET, which has been around for a very long time.
Yeah.
And it's essentially indicated for staging workup for cervical cancer. It loves to go to the lymph nodes first.
Okay.
It just loves the lymph nodes, and it's shocking how just the pattern it follows. It just kind of goes up the lymph channels and actually goes all the way into the left neck before it spreads into the body. Sometimes it can go to like some lymph nodes and escape into the circulation, and usually once it's in the circulation, it likes to go to the lungs. So you're always looking for the lymph nodes. Like for me, when I get my staging PET, I'm always looking for the lymph nodes because I can target those and boost them with the radiation to make sure that I eradicate all the cancer cells within them.
Okay.
If I'm treating them definitively, usually with chemoradiation.
Right.
And then if they have, we've had a couple of patients that unfortunately have lymph nodes going all the way up to the diaphragm and also in the left neck, and we'll treat everything and to try to eradicate it. But the chance of cure in that case, they're technically stage 4, is low. But we give, most of the patients are extremely young, and we just give them a best shot.
Yeah, and this is a young disease, so that's something we should stress too. And I wish I had the graphic. I'm in my head looking at a graphic of the map, if you will, of the lymph nodes. And I don't know if that's something you can kind of describe verbally for our audience, but if you're looking at the lymph nodes of the body, describe kind of where the lymph nodes hang out. Groin, up through the neck. Is there a...
So they hang out by your arteries.
Okay, that's a good way to
describe
it.
So basically they start on the pelvic sidewall, essentially, and then they go up to the aorta. You have your commons, and then they go to the aorta. They go all the way up your aorta to essentially the diaphragm. It can go into the mediastinum. I've seen that a couple of times, but usually once it's there, it likes to go up to your supraclav or supraclavicular fossa. And then there it goes. That's basically where the lymph drains into your circulation.
And then quickly to describe what the job of the lymph nodes are. I always think to myself, they're like
they're filters. They are.
For the lack of a better word, it's a filter.
Yeah.
And so I just like to have people think in their head why it would be important and dangerous for a cancer to get inside the lymph nodes, because it is filtering.
Well, they're stopping the cancer from spreading. So the cancer likes to go into the lymph channels. There's not as much resistance in the lymph channels, so it's pretty easy to get in there. But the lymph nodes can capture them because they are filters. And that patients always ask me, I always use the filter.
I like
because
that. Yeah,
everyone
that's
knows
what I
what
have
a
in my
filter
head
is.
too. Is I'm thinking, okay, is there a better way to describe that? But it makes sense, and people can actually see that in their head too. We're at about 10, 15 minute mark of the show being finished. So what I'd like to do, Kayla, if you don't mind, things that we have not spoken about yet this evening, that in your head you thought, you know what, I want to make sure that I hit on A, B, C, and D. I know we've talked about a lot of the stuff that we've gone out to talk about, but is there anything that we haven't spoken about yet, or something that we have that you just really want to make a big point about before we start wrapping up? So, and then that question too. I should have asked Mr. Travis, Dr. Mendel about this first, because
I have a couple if you want to.
You go first. If you have a couple, because my
it.
biggest one is just the vaccination and getting your screenings.
Right. So in your head, or maybe if you want to bring out your phone right now too, we can give people places to call and or website of where they can get their vaccinations. Maybe you have that on top of your head, and if so, that's awesome.
So Immunize El Paso.
Okay.
Your children in their pediatrician's office.
Okay.
Many primary care doctors' offices also carry the HPV vaccine.
Okay, and you do not have to be a kid. Say if you're just hearing about it now and you're 35.
So you can get the HPV vaccination paid for by insurance up to age 45.
Look at that.
But after age 45, it's usually going to be an out-of-pocket cost.
Okay.
You can also get a prescription and get them done at the pharmacy. Mm-hmm. That's an option as well. And you can also get them done at your OBGYN's office.
And if you need a prescription, I know there's a lot that you're going to have to talk about, but still, and we're going to talk about this again too. If you need a prescription and you do not have a primary doctor, you don't have a doctor you usually go to, where can you or how can you get a prescription?
The best place to go is places like Immunize El Paso, our county immunization clinics.
So we'll make that the main answer in general for that.
I would definitely recommend that.
Gotcha. Dr. Mendel, I know you've got a lot of stuff.
So, I don't have a lot. I just have a couple of items.
Oh, you always have a lot. I love that about you. I really do. Seriously.
But just to hit on the HPV, for cervical cancer, it's like 99% of the time it is caused by HPV. It's like almost all the tumors are HPV positive. Wow. So that's why the vaccine is so important. For men also, there's been an epidemic of throat cancer, oral pharyngeal cancer.
That over the last several years, right?
And it's also another fascinating epidemiologic.
I love that epidemiological.
Yes. But essentially, they I think it was back in 2010 or something like that, they started to realize that the rates of throat cancer in males were rising. And this was, throat cancer before, in the early 2000s, even before, was mainly caused by smoking. And then once people realized smoking's bad for you, they stopped. And so those rates decreased, but shockingly, the rates of these HPV positive oral pharyngeal cancers or throat cancers, specifically in men, started skyrocketing. And they think that, or at least they started noticing that they were skyrocketing. And they think that women are protected because they've already been exposed to the HPV early on in their life. So their body is already essentially inoculated for that virus, but the men are not.
Right.
And so these cancers, they grow in the throat. They're most of them are treated with either surgery or radiation or chemoradiation as well. So we do a lot of these cancers in town as well. But essentially it's, the vaccine will help prevent that as well. So that's another just kind of fascinating side
men
bit.
And women. Mm-hmm.
In men and women.
Exactly.
Mm-hmm.
Yeah.
And then another topic I wanted to talk about was treating cervical cancer definitively with chemo and radiation, and the important logistics you have to get through with that. So like we said, we were discussing before, most of the patients, they will get chemotherapy and radiation, external beam up front, but it's very, very important that they get brachytherapy afterwards.
We kept mentioning it, but we don't talk about it. So describe brachytherapy.
So this is a radiation treatment where we insert a applicator, or we essentially construct an applicator inside the vagina in a metal, what's called a tandem, but it's basically like a metal catheter goes inside the cervix and then treats the tumor from the inside out with radiation. So the applicator's in there, and it's essentially a series of catheters. And we hook that up to what's called an afterloader, and an iridium source comes out, travels down a string into these catheters, and emits the radiation from its radioactive source from the inside out.
And this stays in the body. This is something that's
it's in the patient for a couple of hours while we're doing the planning, and the actual treatment just takes like 10 or 15 minutes.
Oh.
It's very quick, and then we take everything out. The issue here is the tumors are so advanced that you can't just use, it's like a miracle when I have a patient that I can just use a simple like tandem and ring or tandem and ovoid, which are basic applicators that we use for these type of cancers. Here, the tumors are large, they're invasive, and so I'm always having to put interstitial needles in. And so we have a set of catheters that have needle guides, and we're able to extend these high doses out to the side, the pelvic sidewalls almost. And it's funny because when I was in residency, these cases were rare, like very, very rare, where maybe once a month or once every couple of months there would be a patient that would require this type of treatment. And all the residents would, go to the OR, and it was, everyone wanted to put the catheters in because it's sad, but also it's exciting to do a surgical procedure and be in the OR with the gyn-oncs.
Of course.
It's always
the gyn-oncs.
Yeah. So it was something new and different that we didn't get to see very often. Mostly because it's in a lot of, like in Dallas, it's not as, these advanced disease are not as common.
Right.
So here I see them every week. Every single week. Yes, every week. Now.
And I'm interrupting again, sorry, is that El Paso related? Is that this region related, do you think? Or is it just a matter of knowing that this is, just noticing that more of this is going on?
I think
Or
that
both?
it's the location.
You think it's the location?
It's the location. Patients aren't seeing their doctors, they're not getting their vaccines, and this is what happens. And this is a disease that could potentially be preventable, or much easier to deal with, but here it is hard. And it is, it's shocking. Like right now, like almost every day I'm on the west side, I'm doing these type of procedures for the patients in town, and it requires anesthesia. So we bring anesthesia to the office so the patients are comfortable and asleep. We have to coordinate with everything, all the other team. They have to get their labs. They have to stop their chemotherapy. They have all these things, and it is a lot of work. And so it's getting harder to find places that will do it because it takes so much work. And usually nowadays, in the community, the hospital system will have a radiation department that does this, that will take on these large procedures. And so sometimes the patients can go to Albuquerque or Dallas, but that's another issue because a lot of these patients cannot travel.
So we talked about at the beginning of the program. So people who are tuning in just now, they're like, well, why here? What's the case? Why here? Why is that an issue in our region?
I mean, the procedural aspect.
Well, just in general, because we were talking about a significant number of advanced cases here in this region, likely due to, and this is part of the opening, lack of proper screening, limited access to healthcare services, poor follow-up, et cetera, et cetera. So is that something that you and the team in this region has kind of seen? Those are all the issues that, how can we help that? Again, we're here right now, so we're educating. We're trying to get people to proper screenings, to follow up. On that note too, before we wrap up, unless you have something else you want to add to that, I do want to follow up on after someone who's been treated for cervical cancer, you were talking about surveillance, so that there are less chances for it to come back, and if so, that they know how to treat quickly. I know we don't have a lot of time, but I'd love for you to address that
So
really
essentially,
quick.
surveillance is just us, looking for the signs and symptoms of the cancer returning. And usually it includes anywhere, so most of these patients are going to get a pelvic exam. Usually in the very beginning, they'll see us every 3 months.
Okay, that's
And
the
you'll get a
question.
pelvic exam where we're going to look at the areas that were affected. Sometimes it may include blood work that will give us an idea of whether or not the tumor may be returning. And sometimes it will be imaging with either PET scans or CT scans that will tell us that the cancer may be coming back.
And might this be a lifetime going forward? Or is it
So-
like we look a lot for the next 5 years and then we
5
kind of
years,
settle down?
and
Okay.
then after 5 years, we see them once a year. But essentially, most of the time, we see these patients at least once a year for the rest of their life.
Okay.
We turn into their gynecologist.
Right. And again, quickly, I know you talked about it too, symptoms. For people who are tuning in now, what are some symptoms that can be mistaken for something else?
So just like Dr. Mendel said, bleeding. Another big one is discharge, abnormal discharge that does not responding to treatments. Sometimes patients will have a discharge and they'll go and they'll do like a over-the-counter monostat treatment or something and it doesn't work. So if you're noticing that you're trying to deal with this discharge and it's not working, you need to see your provider.
Now, this is a medical show, so I'm going to ask specifically, what kind of discharge are they looking for?
So usually they're looking for a foul-smelling discharge, bloody, yellow to gray in color. And sometimes it's watery.
So if you're just looking for something that just does not feel or
Outside of your normal.
outside of your
Most
norm, that's
women
the best
know
way to
what their
describe it.
normal discharge is. All women have discharge. Every day we have discharge. When it starts to get weird, that's when you need to say, know your body and know when
Right.
it is something's different.
Now it's time to suck it up and go see the doctor. This show was absolutely fascinating. Thank you so much. And thank you, Dr. Mendel, for bringing this to us.
Absolutely.
Kayla, you're an absolute delight. You're full of information. And I hope we get to do something like this again.
She's amazing, right?
She's
Yeah.
pretty dang cool. Yeah.
Did you tell him?
I was gonna
Did
say,
you tell him the cool story of how we know each other?
Yeah. No, I didn't. I was thinking about bringing it up.
Real quick.
We'll find that.
He
we'll
was
find
my
that
medical
soon.
assistant. He was my medical student.
Oh,
Yeah.
hello.
Yeah,
Really?
he was my medical
Talk about a
student.
full circle moment.
Yeah.
Yeah,
I
so-
kind of love everything about that.
And Saldivar was the first surgeon I met in medical school too.
And that's
that worked
the
with.
doctor I
Yeah.
work for.
Jeez.
So that's how we know each other.
Gosh, I want to say thank you so much to Sparrow Women's Oncology, who is bringing this to you. And again, any questions too, I know there's websites, the search engines are great these days. You can look up Sparrow Women's Oncology. I want to say thank you very much to Dr. Travis Mendel, who is a radiation oncologist / all kinds of other knowledge that he's got inside of his head. And then Kayla Castaneda, who is a nurse practitioner, but my Lord, do you have all kinds of information. A big thank you to the El Paso County Medical Society. Again, we've been doing this program for over 26 years. And to watch this again, you can do it at several different locations. You can go to pbselpaso.org and you can find the El Paso physician and then look at the show. And then also EPCMS, which is the El Paso County Medical Society site. That's epcms.com. And you can also go to youtube.com and just enter the words the El Paso physician. And from there, you'll have all kinds of topics that you can see, topics that we've done in the past. And if you have any questions, you can always ask at those websites too. Thank you so much for watching. I'm Catherine Berg, and this has been the El Paso Physician.